In this particular video, we're going to see on the introduction to the pituitary gland. So this is just an introductory video, but really a very important one. So because this is going to build up your basics for the future understanding of the pituitary gland and the related disorders. So let us understand it much better through this video, which is going to be extremely simple. So let us see the basic anatomy, the functional anatomy of the pituitary gland. How does it look like? So when I draw the pituitary gland, I usually tend to draw something like this, even though this is not the exact anatomy, but let us assume this is the pituitary gland. And also, I'm going to put a dotted line, something like this. You might ask me why, because what I'm trying to tell here, this is the anterior pituitary gland, and this is the posterior pituitary gland. You know, the anterior pituitary gland is also referred to as adenohypophysis, and the posterior pituitary gland is also referred to as neurohypophysis. Clear? But why it is called by different names and what is the significance? Let us see after some time. But right now, trust me, this is the anterior pituitary gland, and the anterior pituitary gland and the adenohypophysis has three different parts. One is the pars distalis, and second one is the pars intermedia, that actually forms the boundary between the anterior and the posterior pituitary, and the ever important pars tuberalis. So this is the pars tuberalis. I can write simply as T, but I can write this is the pars tuberalis. I'll tell you the importance of tuberalis in some time. So what is the importance of this pars distalis? This pars distalis is the one that are going to have majority of the secretory cells of the anterior pituitary, which means the cells that are going to secrete a variety of hormones that you see, the classic FSH, LH, then your ACTH, TSH, all these classic hormones are going to come from the pars distalis portion only. That is from the anterior pituitary. That is pars distalis part of the anterior pituitary. Now, you have a very important organ and a very important area in the brain that's called a hypothalamus. And this hypothalamus is going to extend downwards and they form the posterior pituitary, which means the origin is extremely different for posterior pituitary. And since it's a direct extension of the hypothalamus, which means direct extension of the brain downwards, and they form that extension, that's what we refer to as the posterior pituitary, which means this posterior pituitary is a direct extension of the hypothalamus itself. It's a downward extension of the hypothalamus. That's why this is referred to as a neurohypophysis. But embryological wise, if you ask where the posterior pituitary is originating from, it is originating from the neural ectoderm. That is another reason why it is called as neurohypophysis. And which is the origin? That is diencephalon. Why diencephalon? Because I told you it's the downward extension of the hypothalamus, and all the thalamic structures, including thalamus, epithalamus, subthalamus, hypothalamus, including the optic nerve. So all these thalamic and optic nerve structures are originating from the diencephalon only. So which means that is the reason why it is called a neurohypophysis, because it's a direct extension of the neural ectoderm downwards and form the pituitary gland. But whereas this anterior pituitary's origin is a bit different, it's going to originate from the oral ectoderm. So where oral? Typically from the pharyngeal ectoderm. So this pharyngeal ectoderm and pharynx, they form a pouch and upward extension. How diencephalon forms a downward extension from the hypothalamus and forms the pituitary. Similarly, this forms an upward extension from the pharynx, clear, and both unite together to form a full pituitary gland. So, which means that upward extension, that's a pouch-like structure that formed from the pharyngeal ectoderm, is what we refer to as a Rathke's pouch, or otherwise referred to as a hypophyseal pouch. So that's the idea. So clear? So again, hypothalamus forms different structures. You know, this downward extension is called posterior pituitary, and they form another structure here. This is what we refer to as infundibulum. Clear? And they form another area here near the pars tuberalis. This is what we call as a ever important part, that is called a median eminence. So these are very, very important structures and very crucial for understanding. And remember, this pars tuberalis and the infundibulum part, these two are together going to be called as the stalk of the pituitary gland. This is what we refer to as the famous pituitary stalk. When somebody asks you what are the constants of the pituitary stalk, you have to be very sure that it is formed by the pars tuberalis of the anterior pituitary and the infundibulum of the hypothalamus and the posterior pituitary. So these two together will contribute to the pituitary stalk. And stalk is a very important area of the pituitary, because whenever the stalk is damaged, it's going to result in a stalk effect, and it's going to cause a drop in all the hormone levels in the pituitary except for prolactin, which we'll see why later on, because prolactin is under the inhibitory control. So stalk damage will cut the inhibitory control and resulting in excessive prolactin release. So fine, we'll see that later on. So this is a very, very important part of the pituitary gland called as pituitary stalk. And what is the importance of this again? So remember, the neurons that are coming from the hypothalamus, let us assume these are the neurons that are coming from the hypothalamus. They are two types. One, those that come to the posterior pituitary and they don't have any communication in between. They directly store the hormones in the posterior pituitary and they just release them. That's it. So which means these neurons just come and store their hormones in the posterior pituitary and they just release them, which means what you are seeing as posterior pituitary hormones are essentially, these are hypothalamic hormones. They are not actually posterior pituitary hormones. They are generated from the hypothalamus and they are just stored in the pituitary. You know what are the posterior pituitary hormones? These are nothing but antidiuretic hormone, ADH, or otherwise referred to as vasopressin. And second one is oxytocin. If you really ask me what these hormones are just hypothalamic hormones that are stored in the posterior pituitary. They are not synthesized in the posterior pituitary. They are just stored in the posterior pituitary, which are directly coming from the hypothalamus. So these neurons are what we refer to as a magnocellular neurons. Clear? Let us see the origins and all in some time, but these neurons are called as magnocellular neurons. Similarly, you have another group of neurons called parvocellular neurons. Let us assume these are the parvocellular neurons. This orange color structure which I am drawing are parvocellular neurons. And these neurons, please do remember, they do not enter the anterior pituitary at all. Instead, they end in this area called median eminence. These parvocellular neurons, they don't go up to the anterior pituitary. They just end in the median eminence itself. And where in the median eminence, they are going to secrete a lot of controlling hormones for the anterior pituitary, which means they are these parvocellular neurons. They don't secrete your actual anterior pituitary hormones like TSH, FSH, LH and all. Instead, they will be secreting the controlling hormones. These controlling hormones can be stimulating hormones or inhibitory hormones. These controlling hormones can be stimulatory hormones or even inhibitory hormones. The best examples for stimulatory hormones are growth hormone releasing hormone, you have gonadotropin releasing hormone, then you have thyrotropin releasing hormone or TSH releasing hormone, then you have corticotropin releasing hormone. The best examples for inhibitory hormones are growth hormone inhibitory hormone, otherwise referred to as somatostatin, and you can also have a dopamine. This is not an inhibitory hormone, to be honest. The dopamine is actually a neurotransmitter. Remember, this is the only neurotransmitter that is present in the hypothalamus that are released into the anterior pituitary. Clear? So this is very, very important. So only the prolactin secretion is under the control of a neurotransmitter, but remaining all the other cells in the anterior pituitary are under the control of a hormone, not a neurotransmitter. So this dopamine is a very important event. Let us discuss in detail in some more time. So these are the inhibitory hormones. So which means they are going to release the controlling hormones into the median eminence. But wait on, so how they can control the anterior pituitary now? By releasing into the median eminence. This is where your hypothalamic hypophyseal portal system comes into play. So what do you mean by a portal system in the first place? So let us understand what do you mean by a portal system and how does it differ from a normal vasculature. Remember, a normal vasculature you know you have an artery which forms capillary system, which forms veins, and there is a venous to arterial communication after some time, because these veins once again they result in arteries after oxygenation, and this cycle will keep on continuing. So this is a pump mechanism that happens in the heart and the peripheral circulation. So it's very simple, straightforward: arteries, capillaries, veins, that's it. But portal system is not like that. So portal system is something different. They form arteries which form capillaries, all right, they form veins, and they again break down into capillaries, and once again they form a second venous network. So this veno-venous communication is what we are going to call it as a portal system. So the best example you can tell in the form of a portal vein, where you have mesenteric arteries, mesenteric vasculature, which form mesenteric capillaries, all right, they form the mesenteric veins, clear, and the portal vein. Mesenteric veins, obviously all the mesenteric veins join together to form the portal vein, and which again breaks down in the liver in the form of capillary system. This capillary system in the liver we call them as sinusoid. So they break down again and they form veins, which is nothing but the hepatic vein, which is going to enter the IVC. So you can see all these things happen in the liver. So which means this capillary system is predominantly going to happen in the liver. So that is why this is what we refer to as a portal circulation. This is a portal vein. You can see, so the mesenteric veins combine to form portal vein. Why it's called portal? Because again it's going to break down into capillaries, that's called sinusoids in the liver, and once again it's going to unite together to form a hepatic vein, which enters the IVC finally. So this veno-venous communication is what we called as a portal system. Similar thing is going to happen in the anterior pituitary also. So what's going to happen? You know, there is an artery called as superior hypophyseal artery. Let us draw in a separate diagram, don't want to confuse here. So you have an artery called a superior hypophyseal artery. It's the major artery for the anterior pituitary, and it's going to form capillary loops. Where they form capillary loops is in the area of median eminence, and here they break down into veins, and these veins once again they break down and form capillary plexus in the anterior pituitary, and once again they form another venous system. So this is a vein, this is another vein, and there are two capillary systems that are formed. So now this is what we refer to as a hypophyseal vein. Clear? Hypophyseal veins. So what you are essentially seeing here is very simple fact. Again, you have a veno-venous communication breakdown. So which means this is nothing but a portal system is being formed. So what portal system here? This is entering the hypothalamic area and coming back to the hypophyseal area, that is the pituitary. So that's why this portal system is called as hypothalamic hypophyseal portal system. Why this portal system is very important here? Because I told you there are certain neurons called as magnocellular neurons, parvocellular neurons, isn't it? Parvocellular neurons. So what parvocellular neurons do? They just release the hormones into the median eminence, which means these are going to release the controlling hormones in the median eminence. So this is the median eminence, and they're going to release the controlling hormones just into the median eminence, where the capillary loops are formed by the superior hypophyseal artery. But it's very simple and straightforward. These agents, these hormones, will be carried by the capillary plexus into the veins and into this capillary plexus once again, where they are going to exert their controlling actions on the anterior pituitary. Very elegant system. Release in some place, collected by the capillary loop, and transferred to the distant place. That is why these are called as controlling hormones. That otherwise I will be just calling as controlling factors. I told you, when it is carried by the blood and to a distant structure where they exert their effect, this is what we called as a hormone. Clear? So it's a hormone. So they are releasing in the median eminence, carried by the capillary plexus, and they are again exerting an effect in the little distant area, that is in the hypophyseal area, that is in the anterior pituitary. So clear? So the controlling hormones don't directly reach through the neurons to the anteropituitary. Instead, they enter the anteropituitary through the capillary system and the plexus. That's why this hypothalamic hypophyseal portal system is very, very important for the anteropituitary. But on the contrary, your posterior pituitary doesn't have any portal system because it's not needed, because you know very well the magnocellular neurons are going to directly reach the posterior pituitary, where the hormones are just stored in the posterior pituitary and they are released into the veins. So which means here you just have a inferior hypophyseal artery, which is going to form capillary plexus, which ultimately forms the hypophyseal vein. Which means here you don't need any portal system at all, because your hypothalamic hormones through the magnocellular neurons into the posterior pituitary are directly reaching the posterior pituitary, where they are stored and released through the hypophyseal vein. So you don't need really a portal system here. So it's a very simple understanding. So this is the basic understanding of a hypothalamic hypophyseal portal system. Clear? So this is what is first of all very, very important to understand about the pituitary. So where you have the portal system, where you don't have the portal system, all these things are very important. So with this basic understanding, let us move on. So what are the hormones that are going to come from the anterior and the posterior pituitary? So let us take a pituitary for that matters, and we will put anterior pituitary here and the posterior pituitary. Anterior pituitary and the posterior pituitary. Clear? Remember, posterior pituitary secretes only two hormones. We know that one is oxytocin and second one is vasopressin, that is ADH. Before even moving to the actual functions of ADH and your oxytocin, let me tell you that what are the mechanism of action, how they are going to act, what are the receptors. So remember, any hypothalamic hormone, this is a rule I am telling, any hypothalamic hormone, which means anything that comes from the hypothalamus, anything, either from parvocellular neurons or from magnocellular neurons, either from parvocellular or magnocellular, doesn't matter, they will be acting through GPCR pathway only, that is G protein coupled receptor, which means oxytocin and ADH is not an exception. So they are going to have a G protein coupled receptor mechanism only. Remember, oxytocin is GQ, whereas vasopressin is GQ or GS depending on the type of the receptor. For example, V1 receptors will be GQ type and V2 receptor will be GS type. Remember, you have two types of V1 receptors. One is called V1A and V1B. Previously, these V1A receptors are called as V1 and V1B receptors are called as V3 receptors. Now we don't call by that name, we call it as V1A and V1B receptors. But entire V1 receptor is going to act through GQ and V2 receptors are going to act through GS pathway. Clear? Very simple. Any hypothalamic hormone is going to act via G protein coupled receptor and oxytocin is through GQ only. Fine. Any hypothalamic hormone, anything that comes from the hypothalamus will act through G protein coupled receptor. Very important concept. Clear? So these are the two important hormones which I want to tell that come from the posterior pituitary. Remember, these posterior pituitary hormones come directly from the hypothalamus, which means these are actually hypothalamic hormones that are secreted through the posterior pituitary. That's all. There is no formation of these hormones in the posterior pituitary. Very important point. And what are these neurons called? These neurons will be called as magnocellular. I am just recapping. An anterior pituitary, you have two types, because anterior pituitary are the ones that contain cells, actual secreting cells. They are found in the anterior pituitary only. Remember, actually in the posterior pituitary, there are no secreting cells, which means only anterior pituitary can produce tumors, whereas posterior pituitary cannot produce tumors. Which means whenever I tell a pituitary tumor, which means it has to come from anterior pituitary only. It cannot come from posterior pituitary. because posterior pituitary has no cells that are functional, so they cannot produce a tumor that easily at all. Pituitary tumor means it's a anterior pituitary tumor only. So whenever you see, for example, if you see a mass-like lesion in the posterior pituitary, what will you think about? So it's not an anterior pituitary. Suppose I am telling concretely there is a mass lesion in the posterior pituitary. What it must be? This must be either a metastasis or it must be an infiltrative lesion. Infiltrative lesion. This must be a metastasis or an infiltrative lesion. Infiltrative lesion like tuberculosis, sarcoid. So some infiltrative lesions or lymphomatous infiltration, some infiltration, or it could be a metastasis. That's it. It must be a METS or it must be infiltrative lesion. They cannot produce a de novo tumor. That's what I'm trying to tell in the posterior pituitary. So why METs commonly involve the posterior pituitary? Because anterior pituitary, it's very difficult to see the METs. METs commonly involve posterior pituitary, which means if it involves the pituitary, it usually involves the posterior pituitary. So why that is the case? Why? Because we have seen here already, anterior pituitary has this portal system. Posterior pituitary has no filtering system. That is, there is no portal system. That is why the cells can easily reach the posterior pituitary and they form a collection there. That's why you have METs very commonly in the posterior pituitary, if at all it's seen in the pituitary. That's why they will ask you, any metastatic or infiltrative lesion, what is the most common clinical feature? Metastatic or infiltrative lesion of the pituitary, most common clinical feature is diabetes insipidus. Obviously, you have one exception for this fact. One exception is there. That is called lymphocytic hypophysitis. I will tell you that later on why this is an exception. But apart from that, infiltrative lesion or a metastasis to the pituitary, most common clinical feature will be diabetes insipidus, that is due to damage to the posterior pituitary. Clear? Because ADH is secreted from the posterior pituitary. Loss of ADH secretion due to damage to these neurons is what we call as diabetes insipidus or central diabetes insipidus. Clear? So basic understanding. Okay. No cells, no de novo tumors. Cells are there in anterior pituitary, so de novo tumors are possible. In the anterior pituitary. Pituitary tumor means an anterior pituitary tumor. That's all. Okay. You have anterior pituitary. Now, how you will classify the cells of the anterior pituitary? You have two types of cells. One is called a chromophil. I can write like this. One is called a chromophil, which means they take up the stain, right? So it's a chromophil. Phils, they take up, they love stains. Or chromophobes, which means they don't take up stain. That's why it's called phobes. They don't take up the stain. How many percentage? How much percentage? 50% are actually chromophobes and 50% of the anterior pituitary cells are chromophils, which means these are the secretory cells. And these chromophobes are non-secretory cells, which means they don't produce any hormone, but they are functional cells only. So what are making up the chromophobes? Somebody asks you, they don't ask really, but if somebody asks you what are the things that make up the chromophobes, means these could be exhausted chromophils, which means they are once upon a time a chromophil, which are actually secretory. Now they have exhausted their secretion and they're on the verge of apoptosis, and that cells could represent in the pituitary as chromophobes. Clear? Next, you can get certain stem cells and certain supportive cells are there in the anterior pituitary. Those can also look like chromophobes because they don't have that secretory granules. That are the ones that make them take up the stain, the secretory granules that contain the hormones. So this all could be chromophobes. Clear? So if they ask you in exam, which of the following tumors will not be secretory tumor? Your answer must be chromophobe cell adenoma. They don't secrete anything. Straightforward. Chromophils. So what are the chromophils? You have two types of chromophils. One is called an acidophil and second one is called a basophil. Obviously, they take up acidic stain, these take up the basic stains. In the 50% of the cells, how much acidophils contribute? 35%, which means they are going to be the maximum, and basophils contribute only 15%. And what are the acidophil cells? what are the hormones secreted and what are the types of acidophil cells. In that you have somatotrophs and you have lactotrophs, otherwise called as mammotrophs. In that, if they ask you which is the most common or the maximum amount of cells that are seen among the acidophils, that is the somatotrophs. Remember, somatotrophs single-handedly contribute to 50% of the acidophils, overall acidophils, and it's the maximum number of antipituitary cell. You should be very clear about that. It's a very important cell. You know what somatotrophs do? They're going to secrete growth hormone. What lactotrophs or mammotrophs are going to do? They're going to secrete prolactin. Clear? What about the basophils? Basophils, you have different cells and secrete different types of hormones. 3 different types of cells are there. First one we are going to call it as corticotrophs, which secrete a very important type of hormone called POMC. Remember, from POMC only you will get ACTH, because POMC is a big molecule, that is what is secreted, then which is actually processed later on to produce ACTH, adrenocorticotrophic hormone. But POMC is a very important hormone, that is the major hormone that is secreted, that is called pre-opiomelanocortin. Apart from that, alpha MSH, lot of other hormones are secreted. Let us see the structure of the POMC in some time. Pre-opiomelanocortin in the adrenal area. That time you will understand what are the hormones that are secreted. But right now understand POMC, ACTH, that's it. And you have thyrotrophs. If somebody asks you what is the importance of thyrotrophs, this is, remember, this is the least number of cells, least amount of cells in the pituitary. Maximum amount of cells, maximum number of cells in the pituitary, that is somatotrophs, that is mammotrophs. I mean, these somatotrophs are the ones that are going to secrete the growth hormone. These are going to be the maximum, I told you already, 50%. Least, if they ask you, it's going to be thyrotrophs, which secretes TSH, that is thyroid stimulating hormone. Clear? Third one, you have gonadotrophs. What they are going to secrete? They are going to secrete the gonadotropins. They are nothing but FSH and LH. So these are the gonadotrophs. Fine. What are the importance of this corticotrophs? What are the importance of this corticotrophs? Remember, corticotrophs are the first cells that appear in the fetal life. These are the first cells that appear in the fetal life. So if suppose someone asks you, what is the first pituitary hormone to appear in the fetal life? That is ACTH. And the first hormone to appear in the fetal life is cortisol only. And it's understandable because cortisol is a stress relieving hormone and it's a hormone that copes up with the stress in the body. So to cope up for the growing fetal stress in the womb, you definitely need this cortisol and ACTH. So first hormone to appear, first pituitary hormone to appear in the fetus, you have to answer ACTH or cortisol. Cortisol is not a pituitary hormone, but in this axis, HP axis hormone, the first hormone to appear is ACTH and cortisol in the hypothalamic pituitary axis. Very important. Second hormone in the fetal life, if they ask you, answer will be somatotrophs. Second cell to appear is somatotrophs. Second hormone to appear is the growth hormone in the fetal life. The second HP axis hormone is growth hormone only. Do you understand? And that is because to produce the fetal growth, and these are the two mandatory functions, coping of the fetal stress and giving the fetus growth. Both are important. That's why these two are the first two cells that appear in the fetal life. Clear? So these are very important. And what is the importance of this gonadotrophs? Gonadotrophs also have an importance because this is the most common reason. The tumors of this area is most commonly found in a non-functional adenoma. Let us see a non-functioning adenoma. What does it mean? Non-functioning adenoma, usually it is originating from the gonadotrophs only. Let me tell you sometime, don't confuse it right now. So these are the cells of the acidophils and the anteripituitary predominantly. Somatotrophs that secrete growth hormone, mammotrophs or lactotrophs that secrete prolactin, and you have corticotrophs that secrete POMC and in turn ACTH, and thyrotrophs which secretes TSH, and your gonadotrophs that secretes gonadotropin, that is FSH and LH. But let me tell you one important point. All these basophilic hormones are going to act through G protein coupled receptor only. Clear? G protein coupled receptor. GPCR is the mechanism for all these basophilic hormones, which means they are going to act through G stimulatory pathway, which is going to increase the cyclic AMP. All the acidophilic hormones, prolactin and growth hormone, TIN, TUS, GH, GMCSF, we have seen already, they are going to work through NRTK pathway. That's called non-receptor tyrosine kinase pathway, which is nothing but a JAK-STAT pathway. Acidophilic hormones are going to work through JAK-STAT pathway, whereas basophilic hormones are going to work through G-stimulatory pathway, that is GPCR pathway, G protein coupled receptor pathway. Clear? Why I told you this, even though it comes under HP axis, it's not typical HP axis. If you remember this carefully, in the last video I have told growth hormone prolactin I don't consider as a typical HP axis hormones. Why? Because the reason this GH and prolactin, they don't have a specialized target organ. Specialized target organ. They don't have that. They have multiple target organs. They don't have a specialized target site. But whereas for this basophilic hormones, they have specialized target organ, as well as they have specialized effector organ. That's what this target organ is, the effector organ, which means they have a specialized target organ, that is the effector organ. You can see for this ACTH, you have adrenal gland, especially the adrenal cortex is what we're going to tell. For TSH, you have the thyroid gland, which is a specialized effector gland for TSH. And for gonadotropins, you have the gonads, testes and the ovaries, specialized peripheral organs that respond to these hormones. But here, there is no single specialized peripheral organ that responds to this prolactin and growth hormone. There are multiple target sites are there, but there is no single specialized site for this particular hormone. Clear? Very, very interesting. But that's why I told you this basophilic hormones are the ones that typically complete this HP axis, whereas this growth hormone prolactin, you can argue that they are HP axis, but they don't have that specialized effector organ. That's why I don't call them as a typical HP axis hormones. Hypothalamic pituitary axis hormones. Clear? So these are some of the important points. Embryologically speaking, you know this anterior pituitary is going to come from the Rathke's pouch, that is from the pharyngeal ectoderm. But very important for the growth of the pituitary, if they ask you what is important, that is called PIT1. This PIT1 is a pituitary specific positive transcription factor. This PIT1 is very, very important because you will see in hypopituitarism cases, congenital hypoplasia of the pituitary and all, where this PIT1 is really important, mutations of PIT1. So PIT1 is the most important transcription factor that is important for growth of the pituitary gland embryologically, especially the anterior pituitary. Fine. I told you the posterior pituitary is not under any control. It's directly hypothalamic hormones that are released into the posterior pituitary, and you don't have any portal system. This posterior pituitary will not have any portal system. But anterior pituitary, on the other hand, it has portal system. Yes, they do have portal system. They do have this portal system, which means they are controlled by the hypothalamus through this portal system, which means you have the hypothalamus here, which exhibits control through this portal system, which means by releasing a lot of controlling hormones and substances through the portal system, they exhibit control on the anterior pituitary. So they're going to exhibit control on the anterior pituitary. So how the hypothalamus exhibits control? So what are the hormones that exhibit control? For example, the somatotrophs are controlled by two hormones. One, you have a growth hormone releasing hormone. This is called a GHRH, which is a stimulatory hormone. Similarly, it also has a control through inhibitory hormone called growth hormone inhibitory hormone, that is referred to as something called a somatostatin. Remember, the somatostatin was originally identified from the pituitary only. That's why stat means inhibits the somatotrophs. That's why it's called a somatostatin. But originally it was called as growth hormone inhibitory hormone. Clear? These lactotrophs are always under inhibitory control, predominantly under the inhibitory control, that is called dopamine. So this dopamine is a major inhibitory control for the lactotrophs. Remember, all of them are predominantly under stimulatory control, but only the lactotrophs or mammotrophs, which is releasing prolactin, are constantly under the inhibitory control except under special circumstances. But again, dopamine is the one that is going to create a strong inhibitory control on the lactotrophs and the mammotrophs. Clear? You have to understand this. And you have another hormone, probable, we don't know this, whether it is existing or not in the first place, but it's highly controversial. There is something called a prolactin releasing hormone. Only physiology textbooks will tell you this, but we really don't know. No clinical medicine textbooks are very, like concrete, or they are not sure about the presence of this hormone. This is prolactin releasing hormone. We don't know whether it's there or not, but dopamine is a strong inhibitory, and it's the only cell that is a thyrotroph. That's the lactotroph is the only cell that is continuously under inhibitory control from dopamine. And one more, a vague stimulant is there that can actually stimulate the lactotrophs to produce prolactin. This is TRH. That's called TSH releasing hormone or thyrotropin releasing hormone. This is a very important signal. Why, I will tell you in some time when you discuss prolactinoma or hyperprolactinemia, where primary hypothyroidism is one of the very important causes of hyperprolactinemia, where you will see, because primary hypothyroidism will cause excessive TRH. That increased TRH by feedback will result in excessive prolactin also, because this TRH can cause a stimulatory signal to the lactotrophs to an extent. So that's why this is a very important point. Fine. Similarly, corticotrophs are usually under stimulatory control. What is the stimulatory control for the corticotrophs? It is CRH, that is corticotrophin releasing hormone. Similarly, thyrotrophs are also under stimulatory control. That is called a TRH, thyrotropin releasing hormone, which is again coming from the hypothalamus. And gonadotrophs under variable control, even though you can think as a stimulatory control, but under variable control, not really under pure stimulatory control, because it depends on whether it's continuous hormone release or pulsatile hormone release. Depends on that, the secretion of FSH and LH may vary, but what controls is the GnRH. That's called gonadotropin releasing hormone, GnRH. So these are the various controlling hormones of the anteropituitary from the hypothalamus, but postpituitary really don't have any control hormones because they don't need it, because they are essentially the hypothalamic hormones that are secreted through the postpituitary. We have told this point multiple times, so no need to repeat again and again. Fine. What are the mechanism of action of these hormones and where they are originating from? Let us see. So let us see the hypothalamic hormones. Hypothalamic hormones and where they are coming from. What are the source and what are the mechanism? What are the receptor mechanism? First is the releasing hormone, growth hormone, releasing hormone. They are going to come from the arcuate nucleus. Remember, the acidophilic hormones, acidophilic controlling hormones. I'm giving clues actually for you to understand. Acidophilic controlling hormones that control the somatotrophs and the lactotrophs, they actually come from the arcuate nucleus only, which means the dopamine, which is an inhibitory neurotransmitter, that also comes from the arcuate nucleus, and growth hormone releasing hormone also comes from the arcuate nucleus, so which means they are going to come from the arcuate nucleus only. Mechanism is G stimulatory, which means they increase the cyclic AMP. Remember, I told you there is no doubt about that. In general, everything will be GPCR only, because the moment I told you it's hypothalamic hormones means you have to remember it's G protein coupled receptor. There's no doubt. Clear? So in that we are going to see what is happening. So it is a G stimulatory. Suppose if you take a dopamine, I told you this is also going to come from arcuate nucleus only. So this dopamine is also referred to as prolactin inhibitory factor, but no need to know all these things, just called dopamine. And this is G inhibitory. Obviously, it acts through dopamine receptors. It has to be G inhibitory because they act through D2 receptors. These D2 receptors are G inhibitory, which means they reduce the cyclic AMP. Obviously, they have to be inhibitory because this dopamine is a strong inhibiting factor. Number 3, you have gonadotropin releasing hormone. Gonadotropin releasing hormone. So what about gonadotropin releasing hormone? It is going to come from the certain areas in the hypothalamus, which we are going to call it as preoptic area, or referred to as median preoptic area. Clear? So this is where the gonadotropin releasing hormone is going to come from in the hypothalamus, because hypothalamus itself is a constellation of multiple nuclei, isn't it? So the function is again GQ, which is going to increase the inositol triphosphate and diacylglycerol. This is the mechanism. And number 4, you have thyrotropin releasing hormone, which is going to come from the paraventricular nucleus, which is going to act through GQ pathway. And number 5, we have corticotropin releasing hormone, which is also going to come from paraventricular nucleus, which is going to act through G stimulatory pathway, which means they are going to increase the cyclic AMP. This is going to increase the inositol triphosphate and diacylglycerol. And 6th one, you have growth hormone, inhibitory hormone. This is what we currently call as somatostatin, which is going to originate from the periventricular nucleus. Obviously, they act through receptors called somatostatin receptors. We call them as SSTR, somatostatin receptor, and it will be G inhibitory, obviously, because it's inhibitory hormone. Clear? Fine. So these are the important things that you have to know. So in general, your acidophils are controlled by 3 different hormones, isn't it? One is growth hormone releasing hormone, and second is your dopamine, and third is somatostatin, growth hormone, inhibitory hormone. So these 2 are going to come from arcuate nucleus of the hypothalamus, and this is going to originate from the periventricular nucleus. We saw some time back. This is going to originate from the periventricular nucleus. In that, dopamine and growth hormone, inhibitory hormone. So the receptors will be SSTR here, receptors will be D2 receptors here. So both will be G inhibitory. Clear? So G inhibitory type. Whereas GHRH is going to be G stimulatory type. We know that GHRH is going to be G stimulatory type. Similarly, basophil cells in the antipituitary are controlled by 3 different hormones. Again, one is corticotropin releasing hormone, thyrotropin releasing hormone, and you have gonadotropin releasing hormone. This CRH and TRH are coming from a common area called a paraventricular nucleus, and this GnRH is going to come from a area called medial preoptic nucleus. Clear? Medial preoptic nucleus. And the action of this TRH and GnRH. So how TRH and GnRH is going to work? TRH and GnRH are going to work through GQ principle. And this CRH, corticotropin releasing hormone, is going to work through G stimulatory principle. Clear? So we saw that already. So that is why I've organized in particular order. If you see this organization, you will understand much better. So that's why I'm trying to tell it easier by easier with each passing second. So in this video, so this is very easy to understand. So if you know this, so this is how they are controlled by the hypothalamus. Fine. So this is very easy to understand. But we have not seen where this oxytocin and vasopressin are originating from. Where oxytocin and vasopressin are originating from, ADH are originating from the hypothalamus. We told hypothalamus gives rise to magnocellular neurons, which is going to give rise to this ADH and oxytocin. But where in the hypothalamus this oxytocin and vasopressin are generated? Very important point. Supraoptic nucleus and paraventricular nucleus. These are the areas where this magnocellular neurons are going to originate, and they're going to give rise to this oxytocin and vasopressin. But very important for exams is this supraoptic nucleus. This is what the usual question exam. ADH is synthesized from which area of the hypothalamus? You have to answer it is supraoptic nucleus, and probably a little from the paraventricular nucleus also. So I think with this you can understand the entire organization of the pituitary. I think it will be clear. We have seen, even though this diagram looks a little bit messy now, but it's actually quite simple to understand. So quite easier to understand. I don't want to recap, I guess. The most important points, everything I have told you multiple times. What is hypothalamic, hypophyseal, portal system? What do you mean by acidophil, basophil, chromophil, postpituitary, difference between anterior and postpituitary, origin, embryologically, transcription factor, mechanisms, which receptors they act through. Acidophils act through your JAK-STAT pathway, basophils act through G-stimulatory pathway, hypothalamic hormones, everything is GPCR. But there might be GQ, GS, or GA depending on what controlling hormone it is, either inhibitory or releasing hormone. Depending on that, your GPCR pathways will vary. These are some of the questions that are often forgotten in exam by the students. At the same time, it's very common examiner's point of view. These are very confusing things, so that's why they ask very commonly. So I hope this makes clear, and the organization which you have done will be helpful for you during the revision also. So with this, we'll close down this basic introduction to the pituitary gland. With this, we'll move on to the specific disorders of the pituitary gland. Clear?